Well, I am live. It says that I'm live, so everybody say hi. I know Randy is going to jump over and say hi. My name is Dr. Paul Magarelli, CNY Fertility, here in Colorado Springs, but part of the big CNY family, just about we're across the United States and in Canada. Soon Florida, establishing. Hey, Randy, now you're on this side. Hey, Amy, good to see you. Caitlin, Sage, Kate, Kirsting, Puffer, KSKP. I think I'm going to call you. You just have a lovely name. Okay, Sophie, good to join. Thanks for joining me. I really had a great time. Hi, Sophie. And I had a great time playing with this whole adenomyosis concept for you guys this week. All the good news, Dr. Randy Fink is here in town. He's in that process of becoming one of our great docs here. He's going up to visit our dear Dr. Kiltz. By the way, Dr. Kiltz's birthday is on Thursday. I'm not going to tell you how old he is, but that lovely man who's gifted us CNY Fertility. Hi, Misty, Yesenia, good to see you. Janisha, love it. Shannon, good to see you, Shannon. Jenny, catching everybody there. And so that's what's happening. We've expanded now. We have now 5 embryologists on our program, which is another expansion. We just hired another nurse, another 2 front desk people. So again, we're trying to expand out to the capacity. Hey, Ingrid, good to see you. And the goal there, of course, is to provide that personalized service in the most cost-effective way. And so that's the balance that we always keep. But one thing we found is by getting good people taking care of our patients and acting in a capacity as a family. Hey, Amber Kelly Martin, my dear daughter, jump over to Facebook Live. I'm going to be doing a little lecture for about 20 minutes if you want to jump over. And it's on adenomyosis, which is a neighbor to endometriosis. And we're going to talk about that. Hello, Ole Yimi. And by the way, Amber, I missed you last week. Ole Yimi, thank you for joining us. Joshua Banerjee, Dr. Banerjee. It is so good to see you on here. Wow, gosh. Thank you, Dr. As you know, Dr. Banerjee comes out to Colorado, helps us, and I'm trying to convince him to come out to Colorado permanently, but don't tell anybody. We love that guy. Lauren, thank you. I love our staff. I love my staff. They're amazing. Please, if you, Natalie, you're a new patient with adenomyosis, you'll love this talk tonight. Thank you, Joshua. Good to see you. We miss your cooking. Joshua, we miss your cooking. It's just amazing. I love that fish dish you left for us. What was I saying? I'm gonna get lost here. But anyway, tonight I'm going to talk about adenomyosis. The goal, of course, in any of these lectures is to make you stronger consumers. In other words, and hopefully get for you the real data behind what we do as a profession, and that's reproductive medicine and infertility. So I really want you all to really get a keen sense of every disease that I can think of. And I really think I'm in the mood to do the autoimmune issues. That's 2 weeks from now. So I'm going to be doing autoimmune issues. I know age factor, male factors on there, side effects of medicines. It's all great. I'm not going anywhere. Christine Marie, our doula from Syracuse CNY Fertility. Hello, Christine. Coming to you in April. Yay, we'd love to see you. Okay, that is fantastic. I'd love to have you out here. Tiffany Bakal. I can't say everybody's last name, but I can pretty good on the first names. So without too much further ado, I'm going to expand out on this topic today. As I said, the topic today is adenomyosis. And I call it an integrative approach. It's going to be pretty much a Western approach for now. I can get this dear little thing to work here. There you are. Okay. So what is adenomyosis? If you look at the picture on the left of your screen, I think it's on your left of your screen, you'll see there's a normal uterus, and it's made of three parts. You know, you have you can't really tell. Well, yeah, here's the interior. You see my little, maybe you see my mouse. Kind of can't see it very well. But the inside of the uterus where the baby grows is lined, and that kind of tan color is the lining of the endometrium. This sort of pink color around and muscular looking organ, which is the uterus, that's the myometrium. And then this is the serosal level, or the inside the belly level, the peritoneal level of the anatomy. Here's your cervix, right? And you have an external os, external opening. Os means opening, internal opening. So this is pretty much, this is kind of very glandular. The sperm, when the man ejaculates, loves to live there, can live there up to 4 days before it goes into the uterus. So it's a great way for the design to store sperm. Mucus, of course, glands are here. This is the cervix that you get your pap smear. And then this is the internal os, which is pretty much protecting the inside of the uterus from bacteria invasion, that sort of thing. Now, if you look on the right here, you go, well, it looks awful. Well, what's happened is that you see these blebs inside the muscle of the uterus, and that's considered the endometriotic tissue. So the endometrium is supposed to be here. It's not supposed to be in the muscle, but somehow it either, they're not exactly sure, grows on its own through remnants of during your fetal development, or they invaginate either from surgeries or from trauma or simply pathology, invaginates some of the endometrium, gets inside here, and it gets stuck in there. Because every month, right, these are very hormone sensitive. The endometrial lining is hormone sensitive. When you have estrogen, it grows. When you have progesterone, it stabilizes. And then when you take away the progesterone, it sloughs off, and we call that a menstrual cycle. Well, it can't get out when it's in here. So that can cause boggy uterus, thick, boggy. It can cause pain because of the pressure. So what is adenomyosis? It's the same tissue that lines the uterus, the endometrium. However, it's located in the muscle walls or the myometrium. How does it happen? Most people think it's invasion. In other words, it starts growing in, gets stuck, and gets grown over. Treatment depends on your desire. Kind of the number one treatment for patients who have a lot of pain here is, of course, is hysterectomy. Well, that's not going to work for our fertility patients, of course, right? So we have to come up with other therapies. So we use hormonal therapies. Now, we always have, as a last resort, if the pain is excruciating or it's just, it's just getting to be horrible, of course, hysterectomy, and then you can use a gestational carrier, but typically infertility doctors don't like to remove stuff, okay? And it is definitely associated with infertility and recurrent implantation failures, which we talked about 2 weeks ago, and miscarriages. Now, what's the difference between adenomyosis and endometriosis? Well, the quickest, easiest difference I could show you here, again, is the pink part here. The pink part is muscle, and here you see the endometrial tissue are stuck, adenomyosis stuck inside the wall, whereas in endometriosis, it may invade the wall on the inside. It may be squirted out the tubes and invade the wall on the outside. It may grow on all of the various organs within the pelvic cavity, but it really doesn't get encapsulated within the myometrium. Does it behave similarly? Absolutely similarly. So things you hear about treating endometriosis are likely going to be the same things that we do for adenomyosis. So how do you know you have it? Well, everybody may have some cramping, but this is excruciating pain during menstruation. Painful intercourse, where just the penis hitting the cervix in turn causes pain. Now, that could be both endometriosis and adenomyosis. And then what's going to happen is that you may not know which is which, but I can tell you 80% of those folks who have endometriosis have a form of adenomyosis. So there's a lot of correlation there. And then you can have bleeding all the time because it's not forming and functioning in the right way, and anemia, okay, from the bleeding. So what is, in about 50% of the time, though, there's nothing you feel. Asymptomatic means I don't feel a darn thing. This ectopic or outside tissue, it tries to slough off during menstruation, just like the endometrial lining, but it has no place to go, so it gets caught up and impacted inside a muscle. So it's like putting, you gals who know IVF and who do progesterone and oil, you know that when you put that oil inside the muscle, holy mackerel, that hurts for a while. Well, think about that inside the uterus where that oilish stuff, or blood in this case, can compress because fluids can't compress, and so that causes pain. And this causes dysmenorrhea, or painful menstruation, congestive or spasmodic bleeding, premenstrual, menstrual, and postmenstrual phases. This uterine bleeding can actually cause what they call congestion. It's sort of a European way of thinking about it. You can get premenstrual spotting. About 20% of cases, the dyspareunia that we associate, we think is adenomyosis, may also be endometriosis, and of course subfertility, which is the most important topic for today, and then chronic pelvic pain. Now, they've come up with different ways of grading it, how much of the myometrium, where it is, how deep it is. And again, this is not necessarily something for you all to think about, but if someone says, oh, you have a grade 2, it means that the middle 1/3 of the muscle has been invaded by the adenomyosis, okay? If it's a grade 3, it's gone all the way almost to the other side of the uterus. That's just in case you see a report. So how do we take care of this? Well, there's 3 major ways of taking care of it. And I would tell you that probably 99% of infertility patients are managed by pharmacologic methods. Sometimes there are some surgeries that people do, I've never seen it, never done it myself, where they try to divot out the endometriosis. And then other times, of course, hysterectomy, which is not necessarily a good thing for those who are trying to get, well, what's to try to get a baby. So how does the blood angiogenesis, new vessel formation, fit into this whole process? So abnormal uterine bleeding happens down here on the bottom, this pink area here. I don't know if you can see me. I wish I could make a bigger, well, maybe I can. Hang on a second here. Let me use a different pointer here. There we go. There you go. There you go. So abnormal uterine bleeding and subfertility is what you see. But in the pathway getting to this place, you have to have this tissue injury and repair, hypoxia of the tissue, because remember, inside the muscle, it's not going to get a lot of good blood flow because it's stuck inside the muscle. However, they are responsible to all of these inflammatory markers, or markers for transformation and growth. I'm kind of not trying to impress you here, but there's all of these factors that play a role. Here you're familiar with estrogen, of course, progesterone, turning things on and off in these various pathways. But the bottom line, it's this tissue injury and hypoxia that results from it being sequestered inside the muscle that causes these other changes in subfertility and abnormal bleeding. And here you just see another like cross section showing you how the vessels themselves, in angiogenesis, you see this growth of vessels outside an area, and that's basically part of the process of infertility. Now, what does it look like? Well, with the transvaginal ultrasound, which you're all familiar with, you have this uterus which kind of has, it almost looks like a fibroid down here. Here's the top of the uterus near the bladder. And you notice the shape is not really a pear. It's kind of like a dumbbell. In other words, really large and kind of disproportionate, thin on the top, thick on the bottom. So this is called boggy. So on an ultrasound, you can see it like this. It doesn't look exactly like a fibroid, kind of it's dense. Now, if you put color flow Doppler on this, you'd see a lot of vascularity. And then, of course, here's a really nice look. We're using an MRI. So here's a cross section, like sliced this way through the uterus. You're seeing the top of the uterus here, and then here's the cervix down there. But what you notice is here's the endometrium, but look at these little spots inside, like those little lakes that I showed you in the other cartoon. This is how we diagnose adenomyosis. We could do it transvaginally. We can do it with an MRI. So there's some interesting new thoughts on how do we manage patients without removing their uterus. And this is the key, is we don't want to remove their uterus because, quite frankly, that's typically most folks want to carry. So they came up, and this is used for a variety of things. Initially, it was used for fibroids, but then they said, well, wait a second. If we ablate or cut or break or embolize the uterine artery, some of the vessels where the adenomyosis is, you can see it there. If we starve the adenomyosis cells with blood vessels from having some of these collateral blood vessels, maybe we can get some mitigation or amelioration of the pain. And guess what? Take a look at this uterus, boggy, big, lots of lakes. And here is after the uterine artery ablation. You can see much more homogeneous, none of these little lakes in there, much less boggy. So interesting. Well, before you wig out too much, there are many studies that say that there's a number of studies that support that you can support pregnancy after doing this embolization. In the past, we thought this embolization would cause permanent infertility, but turns out it's not. So here you see the results of this study. When they combined the treatment with the adenomyosis treatment, and what they found was about 11% greater reduction in the uterine volume, and apparently that the patients with the worsened syndrome symptoms have the better improvement. And I'm just showing you here. This is a study looking at human reproduction. What is the effect of adenomyosis on IVF? And unfortunately for us, consistently, there's a 28%. This is just showing you a bunch of studies, and this is sort of, this diamond means that it's accumulation of all these studies. It's called a meta-analysis. Says that there's a 28% reduction in clinical pregnancy rates if patients have adenomyosis, and about a 15% greater miscarriage rate. And of course, this is tragic, of course. However, they have shown that if you use Lupron short term, that's not spelled correctly, it resulted in improved pregnancy rates, clinical pregnancy rates. So you can actually come up with a pharmacological way that'll make you feel less pain, but at the same time, improve your chances for implantation. So this was a huge review of looking at miscarriage rates with endometriosis and adenomyosis in those folks doing assisted reproductive technologies like IVF. And here what they found is that women with adenomyosis had an augmented miscarriage risk in IVF. So another big, big study. In endometriosis, they looked at antepartum hemorrhage, postpartum hemorrhage, variety of other things, and they found that that was more associated with endometriosis, not adenomyosis, but definitely adenomyosis was associated with miscarriages in pregnant women using assisted reproductive technology. So we've got to take it seriously. We've got to do something about it. And here you see, this just basically is the one of the meta-analyses. And again, the diamond shows you the sum effect of all of these studies, because you take a bunch of studies to do a meta-analysis, and you can see studies vary, but when you amalgamate and do statistical analyses, it found almost a five-fold, or actually it was approximately five-fold increase in miscarriages in those women who had an adenomyosis. So, and that's really equates more to a 50% increase, okay? Not 5 times. So then the frustrating part about it is most of the studies that I reviewed essentially were inconclusive. They felt like there wasn't enough good studies done yet, that the studies weren't large enough. They know there's an association, but what can we do to help? Well, in this one study, and I just took 2021, there are tens of thousands of studies on adenomyosis, but using just 2021 data, which is just the first 2 months of this year, and I like to look at very recent studies because they tend to summarize prior studies. they found that the treatment of adenomyosis with the use of a birth control pill basically is clinically effective. So long-term birth control pill use. In other words, birth control pills are progestogenic. Therefore, it suppresses endometriosis as well as adenomyosis. There's a question here: what is an adenomyoma? Right. Well, that's a tissue within the wall of the wall of the uterus with glandular tissue. Adenomyosis is endometriosis that's somehow gotten in, is the endometrium getting in there. And the adenomyoma may well carry the same risk, but it probably has a different mechanism, more structural, and I'll talk a little bit more about the structural impact. This other study looked at single versus one embryo versus two embryo transfers, and they found that in women with adenomyosis, they did worse if they were given two embryos than one. And that has a lot to do with the structure of the muscle wall, as well as the differences in the blood flow. So if you have adenomyosis, you preferentially want to get a single embryo transfer, which I thought was very important. In the summary analysis, medical management is effective for symptom control in most women with adenomyosis. What they found was an IUD, a progestogen IUD. Tranexamic acid is just like it's like very similar to what we think of as like Motrin, but it's a different mechanism. And then there's Motrin, non-steroidal anti-inflammatory drugs, hormone contraceptives, progestins, norethindrone acetate, medroxyprogesterone, that's Provera, Dianogest, which is the study there, helps. And then what they recommend is if these initial treatments fail, try GnRH releasing hormone agonists like Lupron. And in another study that I read, and I'm going to go through it now, is here are the things to do if you're going to do IVF and you have adenomyosis. Okay, so number one, use the long protocol. And I'll be honest with you, I've not used the long protocol in a very long time because we tend to use the GnRH antagonist protocol, but this has made me rethink it. It turns out that the longer the period of Lupron exposure, so in a long protocol, you're on Lupron for at least 17 days, whereas in an antagonist, you're not on Lupron at all, but you're only on 4 days of suppression. And so what they're saying is the longer the suppression, the better. They do recommend the protocol being the long GnRH analog protocol, but this means you can only do a single trigger, can't do double triggers. And as a matter of fact, they found that that using the antagonist protocol appears to be inferior and actually inferior to the GnRH agonist long protocol. And the latter appear to be associated with increased pregnancy and decreased miscarriage rates. So not only is it inferior from the standpoint of managing the cycle, but you actually have a higher pregnancy rate and decreased miscarriage rates if you're on the long Lupron protocol. So for me now, this is now something I have to keep in mind when I'm managing my patients. You know, be sure to tell us you have adenomyosis or even presumed adenomyosis. And I'm going to kind of put that on the to-do for all of CNY. I'll just do a blast out of this slide tomorrow to all our docs. The other proposed management for those folks going through IVF is single embryo transfer. Single embryo transfer is the way to go for many reasons, but most importantly, so that you can have better implantation and fewer miscarriages. And then what they're actually beginning to think is maybe these patients do best if we separate the retrieval from the transfer, and that these folks do frozen embryo transfers. Oh, I missed a slide here. Oh, no, here it is. I'll get back to it. This is just talking about hormone replacement for frozen embryo transfers was better. this is what they call two-stage IVF is better, meaning freeze all cycle and then suppress with GnRH analog for 3 months, so you shrink the adenomyosis, then you do the transfer. So you do your retrievals to get those eggs out as soon as possible, freeze them, now put you on 3 months of Lupron, and then come back and do it, and that would shrink, and the current thought is that'll increase your likelihood that implantation will occur. And then what they're recommending, and we do it anyway, is a trial transfer, a mock embryo transfer. And the reason we do that is because of the navigating the canal. So anyway, that's what we do. All righty. Now, that's what I wanted to talk about today. So let me see what kind of questions that you have. Would PRP help with implantation failure from adenomyosis? Jennifer, no clue whatsoever, no studies. Actually, I think it may not, because the whole idea of platelet-rich plasma is for things to grow, grow faster, grow more, grow better. Is microflare protocol okay for adenomyosis? According to this, no. You don't want to do that. You want to have extended, this is Melissa, you want to have extended time with the GnRH agonist, which is Lupron, to suppress and shrink the adenomyosis lesion, okay? That's what you want to do. Is inflammatory and dietary change 100% necessary? Well, this is Rihanna. You know, I get this question a lot. Do I have to? Do I have to? Do I have to? Well, that's an odd question. You have to because you want to get pregnant. I mean, you don't have to because I said. You have to do it because my understanding is you want to do everything possible to achieve a pregnancy. And these are some of the ideas and concepts that CNY is putting out there so that we can improve outcomes better than stuff that we don't know any about. So do you also recommend a long protocol of meds for adenomyoma? It makes sense because adeno just means glandular, Ingrid. I would say go for it. I don't think I've seen a study, but I would say that would likely won't negatively affect and may well positively affect the likelihood of implantation. So Rihanna, you know, just read our family building guide. It's on our CNY fertility website. Read why we're recommending all these wonderful medications and diet, acupuncture, Kils's keto diet, low carb eating, avoiding inflammatory things like sugars. We're doing that. And by the way, adenomyosis is also an inflammatory process. That cascade of look like little compounds or like a PER chart that I showed you, is all of those are inflammatory markers. So lowering inflammation, yes. Is acupuncture back at CNY Albany? I would have no idea, simply call. How do you determine who needs the Lupron therapy for 3 months? Well, Natalie, it's anyone with adenomyosis. Now that I've read this, that's what I'm going to recommend. After you make all the embryos you want and put them in the freezer. After. I want to reiterate, I'm a very strong proponent of get the eggs, make the embryos, store them because they can last 100 years and they don't age. All right. Is it okay to do estrase cycle day 4 and 5 and start stim day 6 and why? No condition. I know it's not related with this topic. Well, Jenny, if you know it's not related, why did you ask it? Just kidding. I don't know. You're just, I think you're asking, can you get a cycle started on day 5 or 6? Yes, you can. Yes, you can. It's better to do it earlier, but sometimes we can only deal with the timing we have. Maritza, there you go. My sister is my egg donor. What type of testing does she need to complete? Can she request from her gynecologist? Absolutely, Maritza. They want to check blood work. They want to check she's going to be the egg donor. They want to check for sexually transmitted diseases, check for hormones, check for the thyroid. Check her AMH. AMH, of course, is going to tell you if she's got eggs. I don't know how old she is, and it's wonderful that she's providing them. But yeah, there's and as we call it preconception testing, because in a way, preconception is not only preconception for the egg, but it's also preconception for the uterus. So yes, and yes, we love to have our gynecologist colleagues provide support. By the way, a lot of times people know I put my name up there. I'm Dr. Magarelli. Sometimes people ask me who I am. That's who I am. I'm here at CNY Fertility and Colorado. Okay. What causes heavily fragmented embryos? I've had this issue 2 or 3 retrievals. Well, Bella, give me your age and tell me a little bit more about you. But fragmentation can be caused by sperm, can be caused by eggs, can be caused by a combination of eggs and sperm. Remember, that's what it does. How about low AMH levels of 0.3? What are the best options? The mini, depending how old you are, Victoria. By the way, if you have kind of an AMH question, always put your age in there because I'm going to ask you anyway. But Bella, now Bella is 40. Yeah, so Bella, part of that is just the age of the egg. Part of it could be the sperm and the egg combination, Bella. And then Victoria, 0.3 AMH means that when they're looking for eggs, there's very few to be found. And so, don't know how old you are, Victoria, but best option if you're over 40 is the mini IVF. If you're under 40, conventional IVF. Rihanna, is Orlis and letrozole much different than priming with Lupron? Absolutely different, yes. Different mechanisms, different reasons, yes. And Victoria, 34, right on the cusp. I would do a conventional IVF, which means normal dose IVF the first time. See how many eggs. Sometimes we're surprised. You get many more eggs than we expected. The mini IVF, it saves you money, lots of money on the drugs, the medications, but eggs are more important than the cost of the medications on the first cycle. Can PCOS affect AMH? Yes, Yesenia. PCOS, we tend to see women with very high AMHs, very high, well above 3. And it's because there's a lot of follicles that are in a sort of a steady state of growth, and those are the ones that secrete the anti-Mullerian hormone, or AMH, and that's what we're actually measuring is active follicles, not follicles that are going to make a baby, simply follicles that are active. So yes, PCOS patients tend to have higher AMH levels. All right. All right, looks like no one has any more. Oh, there's a question. I have endometriosis and adenomyosis. They recommend Orlis and letrozole for 30-day prime. So when I speak to them, it would be recommended to start solely Lupron prior to the FET. Well, you know what? I'll get this out to them tomorrow, and they can make that decision, who's ever making your decisions there. But letrozole is not wrong by any stretch of the imagination because it stops estrogen. So those are... You asked me if they're the same protocol. I said they're not. I didn't say one is better than the other, okay? That's not what I said. So either of those protocols can work. So the Orlis and letrozole can work. Can 2 retrievals be done back-to-back? Absolutely. It's called duo-stim, Susan. Nicole, 36, did mini IVF last year, 1.42 in December. How many eggs did you get, Nicole? If we do another IVF cycle, should I do conventional instead and only get a convention instead with only getting 10 eggs and 4 embryos? No, 10 eggs and 4 embryos is great. So do conventional. Sophia, will the IVF medication change for an adeno patient since nope. The IVF medication will not change. It will not change because there's 2 things happening here, folks. You want to get eggs, you want to get embryos, but you also want to get the uterus ready. So it's a dance. So Vasquez, 36-year-old, AMH of 0.16, failed transfers, having implantation failures, nothing found on lap. What can I do with help with implantation? Do the endometrial receptivity assay, the ERA. Do acupuncture. If you live near someone, great. If not, go to www.aborm.org and find an acupuncturist. Avoid alcohol, tobacco, drugs. Take Serovital, which is a growth hormone secretagogue. There's a lot of things we can do to help implantation failure. Ruby, I'm 33, had 38 eggs retrieved, all died by day 5. My husband's sperm is normal. Well, Ruby, I would think that you did you hyperstim? Because if you hyperstimmed, sometimes that can ruin the eggs, even though the eggs could have been normal. So you may want to do a low, slow protocol. I did IVF with an AMH of 0.2 at 34 and only had one egg, and that could be fertile. Do I try IVF again or consider a donor egg? Well, Victoria, that's a very personal question. We will help you if you want to try again, and we will help you if you want to use. As a matter of fact, CNY has a program where you can do IVF with donor egg backup. That's probably your best way. Nicole, did mini IVF before, not conventional, Nicole. I lost the strain. How can you check if adenomyosis has spread? Like I showed you with the picture, you could do it with an ultrasound or you can do it with an MRI. Have you ever seen success with Neupogen, intralipids, prednisone, baby aspirin, and progesterone for recurrent implantation failure with MTHFR gene mutation? Those are not related, Reiki. Those are not related. Those drugs don't help the MTHFR, which is just a folic acid issue. Why is estrase given day cycle? I don't know, Jenny. I'm not sure why estrase was given on cycle day 4 and 5 before stem. I don't know. Jennifer, ultrasound or MRI? If you can get an MRI, you're more likely to get a definitive diagnosis. Transvaginal ultrasound is pretty darn good, but MRIs are more definitive, I believe. My sister is an egg donor, tested positive for HPV. She's 29. Will this affect her egg quality? No. And her ability to donate, Maritza? No. And Ruby, I'm sorry, I forgot the question. No hyperstim. So why did well, if they die by, what happened, here's the thing. When you do IVF, the first 1 or 2 days after you get the eggs out and look what happens to the embryo is really a sperm issue. The second, third, or fourth day is really an egg issue. And then the 5th, 6th, or 7th day is really an embryo issue, which is a combination of the sperm issue and the egg issue. So it's sometimes hard to sort out. Now, 38 eggs, there's a form of hyperstimulation there. I mean, you may not have gotten sick, but I'm curious what your estrogen level was. Yvonne, what do you think of using Femara for an egg retrieval, and how much Femara will 1.4 mH and how much? So you're trying to do a letrozole IVF cycle? Hell no, Yvonne. Hell no. No, that's gonna. Letrozole is famous for monofollicular development, 1 egg. It's actually famous for not getting more than 2 eggs to grow. Yeah. Reiki, AMH is 7, cause of my concern. Now, that's a good thing. Don't worry about a high AMH, Reiki, because we can manage you, knowing you have the opportunity to give us too many eggs. It's harder to manage you if we don't have enough eggs. So really, that's the story. Rihanna, multiple implantation failure with day 3 embryos diagnosed of endometriosis and adenomyosis, did 30-day prime with letrozole listed. I'm in keto now for 45 days. Could natural cycle be a good try? Again, I have no concept of this term natural cycle and why people even think about it. It just doesn't make any sense in terms of improving your outcome. It's saying I don't want to do the optimal technology. And anybody who doesn't want to do the optimal technology, I don't understand it, because you're coming to a group, reproductive endocrinologists, who do nothing but optimize and make as many, because you want as many eggs as possible. So if you do a natural cycle, I'm not sure there's an advantage there. Would you recommend starting prednisone on day 1 of IUI cycle as part of it? I don't have any idea, Erica, sorry. Letrozole is famous for very few eggs. When you're doing it for ovulation induction, in other words, doing it to do an IUI, when you compare letrozole with Clomid, this is not IVF we're talking about. Letrozole's job is to get the brain to produce 1 egg, 1 follicle. Clomid, it'll do 5, 6, or 8. It just does. We did 10 milligrams of letrozole, 250 of gonal and low dose HCG mini IVF worked okay. Would have liked to get more eggs and more embryos, but didn't want to hyperstim either. Okay, we did. So the letrozole kept your estrogen low. Would like to get more eggs and more embryos, but didn't want to hyperstim either. That's actually a very good protocol. That's a good protocol. Do you need IVF for high AMH? Well, if your fallopian tubes are open, you don't need IVF per se. It's a sperm, and if you're going to do IVF, it's a sperm reason to do it. It's a tube reason to do it. It's an egg reason to do it. It's an egg age reason to do it. So that's the reason. I'm not quite sure why you're saying Dr. K, Nicole. I'm not sure how that relates, but didn't want to hyperstim either. Well, that probably was Dr. K's recommendation. Not sure what that means, recurrent loss. Thank you for focusing on the topic. Not a lot of people know about adeno, and I learned a lot. Oh, thank you, Sophie. I'm glad. Tiffany, 42, low AMH, 0.1, great preconception ultrasound. All other levels are normal. Do you suggest mini IVF first? Yes. Nicole, yep. Melissa, what does Omnitrope do? It's a growth hormone. And it's a growth hormone because as we age, our growth hormone goes down. And we know that that affects every tissue, including eggs and sperm and follicles. So what we hope, and there's some study to suggest that patients with low ovarian reserve actually benefit by giving some growth hormone. Misty Anderson, I'm 40, open myomectomy, 8 fibroids, and endometriosis, failed IUIs. I had 1 miscarriage 70 years. Should I try IVF or move towards hysterectomy? Well, Misty, that's an impossible question. Get a baby. If you want a baby, this is a baby for them. Get a baby, try. The worst thing you could say is it didn't work, but definitely try. As long as they find that the inside of the uterus can hold a baby, definitely. Should we use Clomid for an egg retrieval? No. No. We never use Clomid in IVF. No, you don't want that. No. Can't wait to have my Zoom appointment with you tomorrow. So excited. Oh, thank you, Caitlin, Sage, Kirsting, Puffer, my KSKP lady. You've been so wonderful on these things. I really appreciate it. And, you know, remind me when I get on the line, I'll to just make sure I click Zoom. Anybody, by the way, anybody who wants Zoom meetings with me, just ask, please. Anybody who wants Zoom meetings, just ask. And then, you know, make sure you, I think I'm going to start posting my Zoom ID there. Anyway, let's see what else we got here. All right. Woo! Lots of good questions, folks. Definitely an avalanche of good ideas. Importantly, healthy body is a fertile body. Reduce alcohol, tobacco, street drugs. Women stay away from caffeine. All right, you can have a Zoom meeting. Please look at the family building guide, www.cnyfertility/patient resource family building guide. Kimberly Franco, should we transfer a 4cc with a 2cc, or are they two different? Okay, as you all know, grading is not something I care about. It doesn't make a hill of beans difference. Been proven over and over and over and over and over again. It's interesting. It's a beauty contest, but we all know you can't judge a book by its cover. So your 2cc may be, but anything that has divided or produced a blastocyst, of course, is going to be a benefit. Anything that's chromosomally normal is going to be a benefit. So Jennifer, if you want a Zoom meeting with me, you just call up our 800 number, and I never memorize it. Somebody will throw it on here. But call our 800 number and say you want a Zoom meeting with me. That's easy. Same thing with you, Oleima. Just call us up. Oh, Tiffany, it's my pleasure. I actually have a great time doing these Facebook Lives. I really do. I wonder why I've been put on letrozole protocol to get 1 egg. No. Oh, yeah, no, you're not following this, Oleima. You're being put on letrozole in IVF not to get monofollicular development. You're just putting on letrozole to reduce the amount of estrogen and enhance your natural FSH. The other drugs, I think you were saying only Femara, the other drugs, the Gonal-F, the Follistim, those are the ones that are going to grow lots and lots of eggs, and the letrozole is going to add a little bit to it. How do we get a meeting with you, and how long does it take to get on the schedule? That I don't know, Yvonne, but the way to get on it is just call us up. There it is, 844-31. There's my Jessica. Hi, Jessica. 844-315-2229, which spells baby. So 844-315-BABY-2229. Is a compact embryollar on day 3 a good quality egg? Didn't know if it will grow too fast is bad or not. Well, Caitlin, there's some suggestion that too fast, too slow is never good. But honestly, an embryo growing is a baby potential. When can I call you, Doc? Well, there's that number, the 844 number, 315-2229. Does Neupogen make a significant difference for its cost? Well, I'm not the expert on that, believe it or not. Well, you can believe it because I'm not. So Dr. Kiltz happens to be the expert in this area of immunotherapy. I think that's a balance, Kimberly, that you have to make. It depends on your history. Do you recommend the Receptiva test? Claudine, thank you for asking me that question because I did a lot of homework on that. I'm more impressed with what it can do now. It's pretty good, about 80% effective in telling a person who doesn't know they have endometriosis that they do. So that's pretty cool. And I don't think it's for everybody, but if you have symptoms, but I'm not sure you have endometriosis, I'm thinking, oh, yeah. Jane, found I had a thick than desired lining today. It's impossible. Small cyst on ovaries. I was given birth control for 2 weeks. Good idea. Hoping this will help so I can have my FET. Oh, okay. I see what you mean. In other words, you're starting the cycle with too thick a, you hadn't bled. So yeah, we want you to shed that lining. That's what the birth control pill is going to do. Absolutely, you want a fresh lining. How do you get a more even follicular growth? I always have a dominant follicle that's far bigger than the others in my cycle. That sometimes is biologic. Sometimes you can be cycled for 1, 2, or 3 months on birth control pills, and that can tend to reset the synchronicity. What is it that Menopur HCG doses does during the stimulation phase? Well, Gonal-F and Follistim are nothing more than pure FSH. Menopur is a combination of FSH and either LH or HCG. Well, we now know a mixed protocol with LH in it. Those patients have a higher chance of achieving a pregnancy. So almost universally, for a decade, we did only all the newest, greatest pure FSH, nothing else, and found that our pregnancy rates weren't as good as when we had Pergonal, which had FSH and LH. So Menopur is by Ferring, and they just said, hey, we'll bring back the LH part of it, and you get I think you get a more physiologic development of the lining, not the lining of the ovaries. So Alima, that's exactly right. Alima, and you can add letrozole to that mini, and now you got it. That's beautiful. You're welcome, Claudine. Samantha, so glad you know this. You've done this talk. I have never been able to find any resources online regarding adeno. And thank you, Samantha. It is my pleasure. And by the way, we record all of these. They're recorded in perpetuity on our Facebook Live place. Kimberly, sorry for the cut. I read somewhere that a thick lining above 12 may not be as beneficial as a thinner lining. Is that now, Kimberly? I hope you're not the one who I can't remember. If you're talking about an embryo transfer, linings between 6 and 21 work just fine. 10 is considered sort of the happy medium, but 12 is perfectly fine. There is nothing I recommend for recurrent implantation failure that has to do with. Okay, hold on. I thought you said letrozole. Yeah, no, you meant Lovenox, I think. I don't know. Yeah, Lovenox is helpful for recurrent implantation failure, yes. Jane, okay. Oh, you're never, come on, Jane, you guys are never impatient and confused. Of course not. Yvonne, do you suggest DHEA and CoQ10 and vitamin D and what dosage? www.CNY Fertility Family Building Guide. All the medications are there, all the vitamins are there, all the acupuncture is there, all the keto is there, all the dosages are there. Yvonne, why would you do mini IVF compared to an IVF cycle? If you have low ovarian reserve and you want to save money, that's really the only reason to do it. There's no other reason to do it, is that you are low ovarian reserve and want to save money. But I'm really afraid of mini that I'll not having multiple. Okay, that I'll not have multiple eggs. Well, then don't do it. Then ask for conventional IVF. I mean, if that's what you want, then that's what you do. I mean, that's the reason we're doing mini is if you have low ovarian reserve and cost. Those are the reasons. I love you, Jessica. I really appreciate you. Always here she's throwing out for everybody, family building guide right there, compressed PDF. Really, really nice document made into a book. Fantastic. Hold on a second here. I apologize. I just got a little notice there. Oh, it's almost 5:30. Okay. All righty. Let me take a sip here. All right. As I said, next week is going to be pure question and answers because I try to do every other week a little lecture, but boy, I'm having a lot of fun building these PowerPoints. Kimberly, after multiple failed transfers using each immune protocol, what testing do you recommend to find out what the causing it not to work? Have you done pre-implantation genetic testing, PGTA, on your embryos? Number one. Number two, have you done the ERA, endometrial receptivity assay? That's number two. Number three, have you done acupuncture with fertility trained acupuncturists, either at the Healing Arts Center or you can find them at the aborm.org. Five, are your partner avoiding alcohol, tobacco, street drugs? People whose partners smoke have many, many more failures. Six, and the list goes on. Yesenia, y'all should really teach this military clinic a thing or two. You guys are so informative and helpful. Well, I'll tell you what, Yesenia, I would be, well, I don't know where you're located. If you're located in Colorado, then just ask them if they'd like me to come out and do a talk, an infertility 101. And I'll teach them all the tricks of the trade. I'd be happy to do it. So I don't know where you live, but be happy to do it. So like I was saying, next week is a question and answer. And I think, yeah, I want to go down. I hate autoimmune. I really do. Issues because there's so little really strong, good information about it. When it's so complex, you're in Washington, or I think that's Washington. Is WA Washington? Washington State. I think that's what that is. Yeah, well, get me a plane ticket. I'll go up there. Be happy to teach them. And thank you for your service. I appreciate it. I appreciate it. Okay. Wow, this was very nice. What else can I tell you about? Well, we're just growing. Gosh darn it. We did about 100 cycles in January, 100 cycles and I typically do 10 cycles. A year ago, I was doing 10 cycles a month. Now we're doing 100 a month. That's why every week you hear me telling you we hired this person, hired that person, opened up another 6,000 square feet. It's a fantastic family. CNY Fertility, I mean, they're amazing. One idea would be to talk about the male aspect of fertility. Yes, I do have that. That's an easier one for me. So, Jessica, since you've been such a great supporter, that will be my next one. So that's for next 2 weeks. We'll do the male, okay? I just want to, it's my way of thanking you for being so super helpful. I appreciate that. Let's see. Hang on here. I want to see if my Instagram is still going. Yes, it is. Good. Nobody's there. Everybody come to Facebook. Everybody come to YouTube because Instagram just doesn't work with StreamYard and this is work. Okay. Please come to California, Melissa. Whereabouts do you live, Melissa? We're thinking about it. I don't know how soon. We're definitely. I used to have a practice in Corona, California. Nicole. Oh, I need yes. Okay, I tell you what. That's a great idea. I'm going to do the. Okay, guys. Here's what I want you to do. I'm going to make it a male-oriented talk. So all the husbands, get them their last beer. Get as many husbands next week or 2 weeks from now, and we'll do a really cool male factor talk gals is from the male perspective. So I don't want any, I didn't like what you said kind of things, okay? Meaning I'm going to gear this towards the guys, okay? So if you're going to be on, that's fine, but I'm gearing it towards the guys. But I got to communicate with them, and we communicate differently, okay? So tell everybody that we're going to be doing, and I'll tell my team, we're going to be doing a, let's see, Mag's mail memos. I don't know. I'll come up. Dr. Mag's mail memo. Okay, something like that. We'll come up with something. And it'll be just for the guys. Yeah, it's about time. It's about time we give the guys a little, they really need it. Well, Yesenia, remember, you kind of control a lot of things as a female, and making babies is a partnership thing. So it's all about the partnership. So I think you can be pretty persuasive. I don't have a doubt about that. Yvonne, is there an age limit on patients if they want to try to use their own eggs and keep them? No. One of the big things here, Yvonne, is we will try, if it is at all possible, and you understand the risk and benefits of the procedure. I know many IVF practices have age limits, weight limits, height limits, all kind of limits. No, the Hippocratic Oath says help the patient in front of you. It does not say just pick the best patients to treat. So we here at CNY Fertility, especially with the leadership of Dr. Kiltz, it's all about patient-centered helping people. My staff want to help people. Your doctors want to help people. CNY wants to help people conceive. We do. And so we'll work our damnedest. Sometimes it's out of the box, and most people will tell you it's out of the box. It's just different. But we do well. Yeah, I'm not talking about you, Jessica. That's okay. You don't have to tell us. Oh, God. Why do some clinics do that only based on age or weight? Because we are the only field of medicine that has to publish our results. And once you publish stuff, everybody believes that each clinic is the same, and therefore if one has a higher pregnancy rate, they must be better. And even on the website, which tells you to report the data, it cannot compare one clinic from another. Every single clinic compares, every single person compares. And once you start comparing, then you're going to start picking patients that make your stats look good. And that's sad. That's sad. Rachel, how long after a hysteroscopy with DNC for polyps is it recommended for an FET? 6 weeks. Do I prefer metformin or chromium for prediabetes? You know what I prefer is myo-inositol or avasitol, low-carb diet, keto diet. Chromium is certainly fine, but absolutely, those are the main things. How does scars and scar tissue affect IVF? It depends on where it is, Teresa. If it's in the fallopian tube area, it typically does not. If it's in the uterus, it has to be fixed. So, yeah. So I guess, guys, let's see. It's almost time to say goodbye. I should come up with a song, or I think I'll come up with some music, too, to start and end these. I'll have to think about it. Anyway, I hope you enjoyed the evening. I certainly did. Thank you for sharing your evening with me and asking such amazing questions. You're making me stay young, by the way, because you're challenging me every week to think deeper and deeper and deeper. You guys are smart as anything in terms of the questions and the reading, and you guys are just amazing. So, I appreciate it. I'm Dr. Magarelli from CNY Fertility in Colorado, part of a big, big family. If anybody wants to send kisses, please send kisses. Those are things I like to see. It used to be on Facebook and Instagram, you saw all these bubbly kisses, but with StreamYard, we don't get to see many kisses or anything, but that's okay. I'll give you a kiss. Anyway, thank you so much, you guys. Thank you, Amber. That's my daughter. Thank you. She's my sweetheart here. Okay. Anyway, I thank you all, and I will see you in a week. Next week is question and answer, but tell everybody about that husband special. I'll have to think about that, or male partner special. Anyway, have a good evening, everybody. Thank you. Bye-bye.